Hello class, my name is Holly Moran and my presentation is titled High Refined Carbohydrate Diet and the Risk of Type 2 Diabetes in the Southeast Asian Population. These are the objectives as listed in the guidelines for this project. Let's start off by defining diabetes. Diabetes is a chronic condition in which either the body cannot make any or enough insulin, or it cannot use the insulin that it does make effectively. This results in high blood sugar or glucose levels. The two major types of diabetes are type 1 and type 2. Type 1 diabetes is related to the immune system, while type 2 diabetes is linked to an array of risk factors, including age, ethnicity, family history, and also modifiable risk factors like lack of physical activity or poor diet. This presentation will focus specifically on how a diet high in refined carbohydrates increases risk for type 2 diabetes. These are 3 basic diet recommendations for diabetes as given by the National Institutes of Health. Eat a variety of healthy foods from all food groups. Limit fried foods, sodium, concentrated sweets, and sugar-sweetened beverages. And finally, use the plate method or do carbohydrate counting in order to control carb intake. This is important because carbohydrate is a nutrient that converts to sugar in the body. Refined carbohydrates convert to sugar rapidly, unlike complex carbohydrates. There are various definitions about which countries are included in the Southeast Asian region. For this project, I am going with the International Diabetes Federation definition of Southeast Asia, which includes 7 countries: India, Bangladesh, Nepal, Sri Lanka, Mauritius, Bhutan, and the Maldives. The International Diabetes Federation reports that in Southeast Asia, 8.5% of adults aged 20 to 79 years has diabetes. 45.8% of these adults are undiagnosed. 29.1 million adults aged 20 to 79 years has prediabetes, which is a precursor to type 2 diabetes. India has the second largest number of adults with diabetes in the world. To note, India is the largest country in the Southeast Asian region. In 2017, 12% of total healthcare expenditures was directed toward people with diabetes. And also in 2017, 1.1 million deaths were attributed to diabetes. There are many complications of diabetes, including nerve disease, eye disease, and kidney failure. One does not die quickly from complications. Complications slowly develop over time and are very costly to manage. These facts are among the many reasons why the epidemic of diabetes in Southeast Asia is important to address. Let's take a look at what the Southeast Asian diet looks like. The one presented here is a generalized diet. Of course, since there are 7 countries included in this region, there are slight variations in the diets between these countries. First, the diet is high in refined carbohydrates. Although fruits and vegetables, which are complex carbs, are abundant in this region, they are greatly underconsumed, as stated by Gopalan et al. The diet is high in trans and saturated fats due to the abundance of fried foods. And finally, the diet is fairly low in protein. Many people in this region are vegetarian due to religious practices. Vegetarian diets can be high in protein, but vegetarian sources of protein usually also have carbs in them, which contributes to increases in blood glucose. Southeast Asian diets consist of greater than 60% carbohydrate according to Gopalan et al. The Joslin Diabetes Center recommends that diets for those with diabetes consist of 40% carbohydrate. It must be understood that making dietary changes is difficult because this behavior is complex and it occurs frequently throughout the day. Here are risk factors and determinants to consider in this population. Some of these risk factors cannot be modified by behavior change, such as genetics and ethnicity. To note, Asians are among the ethnicities more vulnerable to diabetes. Diet is a modifiable factor, and a diet high in refined carbohydrates is related to overweight, obesity, and poor cholesterol levels, which are 2 of the factors listed here. The first social determinant is illiteracy. According to the World Health Organization, 30% of the Southeast Asian region is illiterate. This makes it difficult for individuals to read nutrition labels and decide which carb foods are complex or refined. Globalization and urbanization over the past few decades has led to increased availability of highly processed foods, such as refined carbs. There are few nutrition guidelines in this region, and the ones that do exist focus on nutritional deficiencies rather than on chronic diseases, such as diabetes. There are underdeveloped health systems in Southeast Asia. Little attention is paid to health promotion and primary prevention. And finally, vegetarianism related to religion was mentioned earlier. But another thing to consider for culture is the consumption of calorie-dense sweets during festivals. It is considered rude to refuse these sweets when they are offered, so there are also social pressures to consider. The two theories which I found the most literature on regarding dietary behavior were stages of change theories and the social cognitive theory. These theories do appear to be best for analyzing this health behavior. We will start by looking at the trans-theoretical model of change. In the pre-contemplation stage, one is uninformed or underinformed about the consequences of eating a diet high in refined carbohydrates and are not ready for change. Recall that underdeveloped health systems lacking in health promotion efforts is a risk factor for engaging in unhealthy eating behaviors. If one is not aware of the consequences of eating a diet high in refined carbohydrates, then they will remain in pre-contemplation. Nutrition guidelines and programs that raise awareness of the connection between unhealthy eating and diabetes are protective factors. These would allow someone to enter the contemplation stage, where they can weigh the pros and cons of a diet high in complex carbs. In the preparation stage, there is an intention to switch to a diet high in complex carbs within the next month. One may have already started looking up recipes or searching for these foods in the grocery store. If in the action stage, one has been on a diet that is rich in complex carbs for the past 6 months, and if in the maintenance stage, one has been on the diet for greater than 6 months. Knowledge is the first construct of the social cognitive theory. Recall that illiteracy is a risk factor, so any education that is done in this population may need to be in a visual or picture format. Content knowledge would entail learning which carb foods are complex versus refined. Procedural knowledge would entail learning how to select complex carb foods and prepare meals that include these foods. For self-efficacy, one can engage in a vicarious experience by observing others select foods and prepare meals. One can also try an active attainment by enrolling in a class to be guided through the process of food selection and cooking. Positive outcome expectations can be difficult because you cannot observe immediate feedback from eating healthier. The best way to observe a positive outcome is to do blood glucose testing to see if eating better carb foods will lead to lower blood glucose levels. For goal formation, smaller measurable goals, called sub-goals, are easier to meet. One can change one type of carb food at a time, such as switching from white rice to brown rice. Considering socio-structural factors, a supportive family who is willing to make meals that contain complex carbs is a protective factor. Having greater access to complex carbs is also a protective factor. Of all the intervention studies reviewed throughout this project, these are some of the more successful ones that I've found. The first study uses the trans-theoretical model of change. It evaluated a 5-year lifestyle change program in young Sri Lankans at risk for diabetes based on the Indian Diabetes Prevention Program. One specific dietary goal was the avoidance of sugars and refined carbohydrates. The program was considered successful because the intervention group had a higher ratio of recommended to non-recommended food items. The second study evaluated a community-based diabetes education program in the United States. It consisted of 3 2-hour nutrition classes. Researchers used both the stages of change and social cognitive theories. The social cognitive theory results were positive. Knowledge and self-efficacy significantly improved post-intervention. The third study evaluated a cooking school program based on the social cognitive theory. Nutrition information included in the program focused on meal planning and identifying sources of carbs. The program resulted in decreased intakes of several nutrients, including carbohydrates. I believe that the best theory for an intervention regarding the behavior of eating a diet high in refined carbohydrates in the Southeast Asian population is the social cognitive theory, especially the constructs of knowledge, self-efficacy, and sociostructural factors. According to DiClemente et al., social cognitive theory asserts that social environment, the characteristics of the person, and behavior interact and influence each other. When changing diet, you need to have knowledge, skills, and confidence to be able to select healthy foods and prepare them, and you must consider how the social environment will play a role in all of this. My intervention would be a cooking school program. As discussed earlier, I found 2 cooking school program studies that were based on the social cognitive theory, and they both showed to be successful based on their results. Remember that the social cognitive theory evolved from the social learning theory, as stated by DiClemente et al. This means we learn by watching others and imitating them. This is exactly what is done in a cooking class. Cooking is important because this skill allows one to have control over which types of carbs they eat. When you eat out, you will most likely be served more processed, refined carbohydrate foods. Pre-tests and post-tests would be administered to assess the constructs of the social cognitive theory. Participants will be encouraged to bring a family member, which would hopefully improve self-efficacy. There would be 3 classes in total, replacing white starches with whole grain starches, incorporating more fruits and vegetables into meals, and preparing lower sugar desserts. Meals prepared in the class will be based on traditional Southeast Asian meals, but will include more complex carbs and less refined carbs. Participants will be given recipe books and sample grocery lists. These intervention strategies are based on the strategic planning framework as given by the Center for Substance Abuse Prevention. For assessment, you'd need to gather quantitative and qualitative data about the current consumption of refined carbs in the population. For capacity, you need to find available resources to support the cooking school program, such as key stakeholders who will fund or authorize the continuation or expansion of the program. For planning, you need to assemble a team and develop goals and objectives and ensure that they are culturally competent. For implementation, you need to look at other cooking school programs that already exist, such as the 2 that I had mentioned earlier, and adapt them to the Southeast Asian population. And finally, evaluation. This is where there's collection and analyzing of information about the cooking school program. You need to evaluate the results of the pre and post tests, and based on these, assess if the program made an impact. These are ethical concerns I would take into consideration when planning this intervention. First, I would ensure that the benefits of the program outweigh the costs for the participants. For instance, the complex carb foods recommended in the program must be affordable and accessible to the participants. Second, we need to ensure to respect the culture of the participants by including meals that are traditional to their culture. And finally, ensure that key stakeholders are motivated by the outcome of reduced diabetes and complication rates, not by profits. In conclusion, diabetes management, especially the behavior of changing diet, is a very complex thing. Southeast Asians have many risk factors for type 2 diabetes and underlying determinants that contribute to the behavior of eating a diet high in refined carbohydrates. Many interventions have been implemented to address dietary behavior related to diabetes, but very few have been in this population. A cooking school program based on the social cognitive theory may be an effective intervention for changing dietary behavior in the Southeast Asian population. These are my references, and thank you so much for listening.